So just switch things up a little bit. Vidal had a last minute obligation that he couldn't be here, so we're gonna do some cases. We have our fellows here, Tim and Sam, and also I think ortho fellows are here too. So Lionel, you can have the honor. Okay, so you can pick somebody. Yeah, who do you want to take this? Okay, so this is a 58-year-old gentleman with some medical issues, but presented with progressive neck pain and basically myelopathy symptoms. Have some diffuse weakness, hyperreflexic.
Okay, great. I'd like x-rays.
Yeah, so what can you see on the x-rays?
So there's spondylotic changes at 4-5 especially, and a little bit at 5-6. Maintained lordosis.
Okay, so spinal alignment overall looks pretty good.
Yeah.
And what do you think about the canal diameter, or does the patient have any congenital stenosis based on the x-ray, or how do you tell?
Well, you can look at the ratio of the canal to the vertebral body. It looks to be certainly less than 50%, or you can measure the cross-sectional diameter on an axial cut of an advanced image. I would, yes, it looks like there's congenital stenosis.
Yeah, definitely. You can definitely calculate the ratio, but the one quick and dirty way to look at it is actually, as you know, the spinal alignment lines here, if it's really overlapping the facet shadow, means that the pedicle is very short. So you can actually just take a peek at that. The normal spinal canal, spinal alignment line will be probably back there instead of right overlapping that. So in these patients, you look at the x-ray, and if that's overlapping, you have a pretty good idea they have congenital stenosis, and if it's an older patient, probably cord compression. So tell us about this image.
So on this image, there is moderate to severe stenosis at 2-3, 3-4, 4-5, kind of throughout the cervical spine. There is a pannus above the dens and posterior to the dens. I would be suspicious for rheumatoid arthritis in this patient. But there are stenotic changes. I'd like to look at the axial cuts to further classify those, especially at the lower levels.
Okay, yeah, no history of RA, and axial shows that's pretty severely compressed. So any additional imaging you want to get?
Yeah, I'm suspicious for OPLL in this patient in particular. There's signal changes and thickening of the PLL on this MRI behind the vertebral bodies. So I would get a CT scan on this patient.
Yeah, I think Dr. Hart told us, East Asian population is very prevalent. This is actually an African American gentleman. Let's say you got a CT and it shows OPLL. How would you treat this? Anterior, posterior, combined? Well,
I thought I agreed with the algorithm yesterday. I thought it was very thorough. I mean, this is definitely more than 2 levels. The alignment is maintained. There's lordosis. I would further assess the facets on the advanced images, ask the patient if how bad their neck is troubling them in particular. I would favor a laminoplasty, I think, for this patient, but from the talk yesterday, maybe a posterior fusion plus laminoplasty may lower the C5 palsy rate.
Yeah, sure. How many people would do anterior with this? Yeah. How many people would do posterior only? How many people would do anterior then posterior? Posterior then anterior? Yeah, so I think most people would agree going back, posteriorly first, given the long segment stenosis. How about laminectomy and fusion? How about laminoplasty? Okay, yeah, so mostly lamine fusions. saw Dr. Ha just walk in with coffee. Would you do a laminectomy or fusion or lamoplasty for this case? Put you on the spot. Lamoplasty, yeah. So this actually, this patient was seen at outside hospital first, and they did neither actually. I think what they did do is a laminectomy and then did an onlay fusion. You can see the bone graft kind of on the side. So of course, the C227 SVA was normal before, and now it's collapsed to about 9 centimeters. And Chris has published on this. Increased 2 to 7 SVA. Leads to pain and disability. And, this patient actually was worse off after the surgery, having a lot of neck pain. So what now? And the persistent myelopathy symptoms. And this is the CT and the MRI we got at UCSF.
So, how far out are they from the original?
About a year.
Oh, 1 year?
Yeah.
So there's persistent stenosis at 2-3. The stenosis below looks like it has resolved. I don't think that any fusion has taken, probably pseudarthrosis throughout. I'm not sure what their goals were with the surgery besides the decompression, but they did put bone graft, so presumably they wanted it to fuse. I would, at this point, I would do a revision fusion and decompression at 2-3. I'd look at the anterior neck to see if it's favorable for a ACDF at that level. I'm not sure. Yeah, it looks like could probably do an anterior approach at 2-3. So maybe a front back now at this point in time.
You would do a 2-3 ACDF and then limited fusion from at the 2-3?
No, I would fuse the entire segment that they attempted to fuse.
Yeah, because go ahead.
Sorry to interrupt. Would you do an ACDF or would you do a corpectomy?
Yeah, partial corpectomy at 2-3, maybe full corpectomy at 3.
Okay, what are some of the concerns with OPLL? Doing a corpectomy, Dr.
The biggest concern is the risk of durotomy. I think you could let it float and avoid that complication, but it is a risky procedure.
Yeah, so sometimes actually when you sometimes there is some residual dura. Other times when you go in there, it's just bone and then arachnoid and CSF. So, but yeah, I agree. So yeah, revision, posterior decompression, and try to restore some of that 2 to 7 SVA. But at this point, it is actually a lot. It's not fused, but it's kind of stiff. So you can't really get to the complete correction of the SVA, but it's better. And post-op MRI on the right, you can see the canal is better after the revision decompression. So now he's 6 months out. He's a barber, actually. He wants to cut hair. But 6 months out from this revision surgery, he's still having issues. Actually, I fell a couple of times. He's not happy with how things are. And he says, Doc, can you do anything else for me? What would you do at this time?
Yeah, there's persistent stenosis. There's cord signal change, again, behind 2-3. I think that really should be addressed to give him the best outcome. There is neutral alignment at most. I think, again, I would favor an anterior surgery at that level.
So you would do a C3 and C2 corpectomy?
Partial corpectomies, yeah.
Partial.
Yeah.
How would you do the partial corpectomy at C2, and how do you support the anterior column?
Well, you're right. You'd have to violate the end plate and certainly risk subsidence of the cage. I'd have to think about what type of cage I'd like to use, but I think it's the best option here. Yeah,
but I think your thought process is perfect. I mean, on the axial, you can see there's still quite a bit of anterior compression from the OPLL mass at the 2-3. A lot of it is behind the C2 body inferiorly. So we talked to him about doing surgery. So exactly what you said is C3 corpectomy, but instead of taking part of the C2 completely, basically do a trumpet osteotomy up. The C3 corpectomy defect allowed you to kind of look up enough to resect the OPLL mass and get a good decompression. But yeah, so complication happened with OPLL. This is actually pretty stuck. So we resected most of the bone and the arachnoid is intact. Went to get the last piece, pull it down with a curette. Of course, poke the hole in the arachnoid and you see clear stuff coming out. So what now? How would you manage this?
You try to visualize it. That would be, that's a very difficult situation. If it's a poke hole, perhaps it will seal on its own like by the end of the case. But if you can't visualize and repair it, I think you can put various collagen synthetic.
Totally agree. So
flaps.
If it's coming from ACDF or normal corpectomy, if you can put a stitch in it, that's probably the best way to repair it. In this case, there's nothing to sew anything to it. So what we did is put a gel foam to cover the defect and then put some glue, just gingerly. You don't want that to expand and push on the cord. And then you put the cage in front. Then we close the wound. You can place the people on lumbar drain post-op to sort of divert the fluid. So this is what happened with his case. We closed the wound. He actually developed a goose egg post-op, watched for a few days, and nothing was leaking, and he was swallowing fine. We actually sent him home with very close monitoring, and a week later is the image on the right. So, but yeah, if it's persistent, I may have to explore it. But I thought this is a good demonstration of the OPLL, different types, and this one in particular was high up. I think initially, if they did a Lamy fusion, perhaps and got the cord drift back, perhaps it would be better than the laminectomy, the onlay fusion. Yeah, Chris.
It's always easier in hindsight, but do you think when you see that picture of the OPLL at 3, that if you had gotten a better correction, or whether they got first surgery, revision surgery, if you got the better correction, potentially you could achieve better spinal cord growth migration, and maybe avoid that.
Yeah, that's
Maybe we should see that in the future.
Yeah.
In the future of all of us, we should really try to be more aggressive in the interposterior surgery or osteotomy, try to get that correction to avoid the go up to 2-3. That's a very good surgical result. That's really impressive. And maybe, but that's very difficult. What you did was very difficult up at that level, and maybe that could be a better correction.
Yeah, I totally agree, Chris. And that's the original idea. I told him that we'll put you on Gardner Wells and yank your head back as much as we can and get the lordosis. You saw there's some improvement, but by the time he's pretty stiff already. So we weren't able to, especially at the C1-2 sort of segment, to get the focal lordosis. But that's a great point. But I think in these cases, generally speaking, you can always do the posterior first, see how the patient does, get an MRI, follow up. The images don't have to be perfect. If they're clinically well, then you're probably done. But in this case, again, he had falls and he couldn't cut hair. Actually, now he's about 2 years out and super happy. So great job. Sorry for putting you on the spot.
A great case, thank you.
You knocked out the bar.
Yeah, great job. All right, another case. I guess we'll pick on our own fellow. Praveen, who do you want to do this one? Sam or Tim? Okay. All right, 53, with history of epilepsy and worsening myelopathy, arm numbness and weakness. She's got some left arm weakness, hand weakness, 4 out of 5, and myelopathic findings. So Sam, what do you see here? Okay, so cervical kyphosis, not completely overlapping spinal laminar line, but it's kind of close, right? Like the white canal, it's almost double distance of the facet depth. As you know, we talked about this in clinic. So, okay. And here's the MRI. What do you see? So yeah, the cut is at 4.5 and then 5.6.
4.5 and 5.6, and definitely cord signal changes at the level of the stenosis there, central disc herniations at these levels.
Okay. So what else do you want, or are you ready to make a surgical plan?
I'd like to have a CT scan. Yeah.
Okay.
Okay, so significant. So this is 2, 3, 4, 5. So 6 mainly, the vertebral body of 6, and there's a calcified disc there, just protruding into the canal. I'd like to see, like the flexion extension films. We had like an upright film, but I think with the evidence of myelopathy, that would be a case for a corpectomy at the level of C6, and just to try to get this posterior part of the vertebral body and the disc, and ACDF above and below.
Okay, so you want to do 4.5 ACDF and then C6 corpectomy?
Yep.
Okay. Are you worried about anything after the last case?
OPLL and the CSF leak, basically. Yeah.
Right. So we're the special, expert in managing anterior cervical CSF leaks now. So you're not feared. You're not scared about that anymore. Just go for corpectomy.
I mean, the other option would be like go posterior, but I felt like the compression is really coming from the anterior part. But definitely, I can offer the patient also the posterior decompression and fusion.
Okay, and what parameters would you use to kind of help you decide whether anterior or posterior is better? Is there any radiographic parameters that's published that could potentially help you? I don't think we talked about this, but have you heard K-line?
The K-line.
Yeah, K-line, yeah. C2 and C7 K-lines.
Yeah.
And when you draw the K-line, sort of that the C6 mass is kind of just past the K-line. So you can see the occupancy ratio is just over 50%, maybe close to 60%. And it's kyphotic, right? So would the posterior approach be?
With the posterior approach, with the kyphosis, I mean, I'm not probably going to be able to restore much of lordosis unless I do facetectomies, but might not be ideal alone.
Okay, yeah. So, of course, kyphosis with lemoplasty, it's probably not a great idea. You could try laminectomy and fusion, perhaps, but when you have a significant ventral compression, like you first suggested, the corpectomy would be good. What's another option other than corpectomy?
So I'll go posteriorly, do facetectomies and fusion.
Okay, and I think Dr. Ha mentioned this technique, vertebral body sliding osteotomy is also a option. So I think all those things you mentioned is very reasonable. And in this case, we did a 4.5 ACDF and then did a C6 vertebral sliding osteotomy. So some of the techniques I think Dr. Ha mentioned and Dr. Dong-Ho Lee have published extensively. But when I did this case, I think it was helpful to leave the Caspar pen in the body you're trying to slide, so you actually have mechanical control of the body. And then preoperatively, we measured, this to be about 7 millimeters. So once you do the discectomy above and below and make the lateral troughs, that segment is basically free but stuck to the dura for the most part if you have OPLL. So you can tug on it until you feel sort of a gentle tension, and then basically putting cages above and below to secure the bone fragment or the segment in place, and then you can basically use a burr to shave that anterior part about 80 millimeters, and you can get a good good decompression there. So in this case, basically, we avoided the risk of having to deal with the OPLL and the DRA interface, and got a decent.
When would you consider going posterior also, like?
Yeah, mainly because of the kyphosis in the kyphosis of the cervical alignment on flex X, it doesn't completely correct. So worry about the amount of correction, posterior cord drift. Also worry about the amount of ventral compression that's present. But I think certainly you can do a posterior lami fusion and see how the patients do and how much the cord drifts back, and then just like the last case, decide whether you need an additional anterior approach or not. But yeah, I think in this case, this is the sliding osteolat being worked out very well. Again, this is actually not the East Asian patient; she's Caucasian. So surprisingly, all the people coming to UCSF with OPL is non-Asian. All right, we're right at time. Good job, Sam. I don't thank you. And for anyone who's interested in the sort of surgical details, we publish this on operative neurosurgery.